for me to be back home and see all my family. Yes, definitely I left here and I did come back to present. I did over 250 allotransplants. Since I joined USC in 2016, we got the top survival rate of transplant for 5 years in a row by CIBMTR, and I treated over 300 ALL cases. And definitely I'm so grateful to the whole team, to the experience that I had. And today I have a few 18 minutes to cover a lot of exciting breakthrough data in acute lymphoblastic leukemia. So this is my disclosure, no conflicts of interest. I'll start with the case, 19-year-old Hispanic patient, come to the hospital with bruising, fatigue, bone pain, and fever. Blood count showed increase in the white cells count with anemia and thrombocytopenia. We saw blast on peripheral blood. Of course, first question is, we have our road or not? That's a Friday night, and Eric is on call, Dr. Widower, and we see our road and APL is coming. So we look at the smear. There is flow, BCL, ALL, biopsy confirmed diagnosis of BALL, CD19 positive, 20 negative, 22 positive. What information we need to help in the discussion? For prognosis, decision of starting the treatment, long-term plan for care, duration of treatment. What scenario would encourage us to go with chemo-free regimen in these cases? So ALL, it's a common leukemia in children. In adults, it's less common, more B than T cells. Despite the whole advance, even we have high complete remission rate, we still have chance of, I would say, 60–70% long-term. We still have like to face the challenge in the achieving long-term remission in older age, because as you see, 30–40% will remain in remission. We did a great job at St. Jude, pediatrics group, us in adults. As you see the Kaplan-Meier survival, with the years advance, we improved the survival curve. I mean, we're approaching like 80–90% at more in children, and in adults remain a challenging field. Bone marrow biopsy is required. When we talk about prognosis, what we do next, we have to know age matter, of course, because the biology of disease is different from AYA to young adults, to adults or older age. As you see, 39-year-old and older Kaplan-Meier survival for GCO paper or raw blood articles long time ago, we still face a challenge to have long-term survival over 50% in those older age. When we talk about older age, it's 39-year-old and older. If I transplant 78-year-old, so what's my definition now for older? Older, it's 80 and older, because people are fit and they do great these days, and definitely the disease biology is different. So in the next slide, I'll show you. This is the Kaplan-Meier. Despite high rate of response for induction chemo, 30–40% adult patient will achieve long-term remission. In older age, we still have 6–20% in the best case scenario of 5-year survival. This is not what we want. And you see the different color. The blue, yellow is the bad mutation that you see it more common in adult and older age. But 12, 21 translocation, the chromosome 9 and others, it's more in young age. This is a nice review article summarizing to us the biology of the disease is different. We see more Philly-like, we see more high risk with Philadelphia, complex cytogenetics, and the MLL in the pink in adult and older age as well. So Icaro zinc finger, it's also additional mutation that we see more common in Philadelphia and Philadelphia-like, carry high risk of relapse, and the survival of Philly negative compared to Philly-like or Philly positive. As you see, green down to red and black, survival is worse. But now the question is, how do you risk stratify those patients? NCCN guideline, COG, CALGB. Long story short, if you have hyperdiploidy or you have trisomy of chromosome 4, 10, 17, and the 12 to 21 translocation, those are good. The rest are bad. And if you see the survival curve on the blood articles, of course, if you have the 814, 922, even chromosome 11 translocation, complex cytogenetics, hypodiploidy with tetraploidy, those are less than 30–40% survival. CALGB added a little bit of different risk stratification, the balance and the chromosome 7, and of course, in the high risk, now chromosome 8, gain of chromosome 8 added as a high risk. TALL, I remind everyone, the rule of NF and RP. Notch 1, FBX W7. Those are a good mutation to have without having RAS or PTEN. So those are the patient who does good. Otherwise, they don't do good. We call it the NF mutation positive without the RP. And the survival curve drop if you don't have that combination. How many of us, we have this information, newly diagnosed TALL? It's rarely, unless I call my pathology and talk to them about it. Then next step, we're going to depend on what? Minimal residual disease. MRD in pediatrics and old age, meta-analysis, and in older with transplant from the Swedish group, as you see, survival and relapse rate is higher when you don't achieve MRD negativity after a couple of induction, I would say 9 to 12 weeks of starting the treatment. So MRD now is the strongest prognostic factors. If we combine cytogenetics and MRD, I will tell you MRD will get the bad cytogenetics to the good risk when you achieve MRD negative, even in the high-risk cytogenetics in both B and TALL. That's why I was like, calm down. If my fellow doesn't give me the information of cytogenetics, I will make sure he get me the MRD results, because that would be my next step to decide about transplant versus not transplant. A lot of data for how do you follow MRD, by flow or by the full gene sequencing. I mean, identifying the heavy and light chain of the driving clone by immune adaptive technology from pediatrics, from adults, as you see. Even if you achieve MRD negative by the flow defined by 110⁻⁻⁴, if you still identify 1 out of 10 million on NGS, risk of relapse is higher and disease-free survival is lower. This is our data. We published also with my team in the Myeloma Leukemia Journal, and we showed that NGS is better. And even if you have a multicolor flow negative, NGS positive, they do worse. And we did have a cutoff point of 1 out of million cells identified as an MRD positive. And that was my all-day justification of using blinatumomab for a while. And people ask me why you have the top survival rate in transplant and ALL induction. Because in Philly-like, that's majority of my practice, all Hispanic, older than 39-year-old, high risk of relapse. And we know Philly-like, it appears like BCR-able. However, mTOR, MAP kinase, and others, the most common mutation that we identify by FISH immunophenotype is the CRLF2, the cytokine receptor-like factors. And then we do check for Icaro zinc, EBF1, and PAX5. And if they don't have it, 10% of them, they will have interleukin-7, JAK1, JAK2, ABL1, and the others, PDGFR, alpha and beta. So it's important to identify Philly-like, because we know they don't do good. As GCO paper showed us, survival dropped from the blue to the yellow. And of course, when you have CRLF2 expression, doesn't mean it is a driver, it's expressed, but Philly-like, one of those that I mentioned earlier, is driving the clonal expansion. Those patients has high risk of extramedullary relapse, CNS involvement, high risk of relapse, and dropped of survival. We did publish this data too also, and we described the Philly-like in our center in majority of Hispanic population. This article is available, and as you see, majority of our Hispanic patient has the CRLF2 rearrangement, and translocation confer worse event-free survival and higher risk of relapse, even in the setting of using immune therapy in the upfront setting as well. How we treat? Everybody here, if you have ALL, you know it's not 1 time or 2 months treatment. It's a commitment of many, many years of induction, post-remission, intensification, and maintenance therapy require at least 2 years to 3 years. And you have to make sure they get 10 to 12 intrathecal chemo during the course of the treatment. Please don't forget for East Asian and Hispanic to test for TPMT status and the NUDT15 gene, because if they end up with myelosuppression and liver toxicity, and we don't know what's happened with their chemo regimen, we need to know if they carry those mutations. Very exciting advances from Yaghmour and MD Anderson. As you see, the timeline, we have now blinatumomab, inotuzumab, recently the blinatumomab in MRD, negative consolidation that was presented by Lenzo, published from the ECOG 1910 randomized trial that showed us overall survival even in MRD negative, novel combination regimen. Now we have more technology in MRD by NGS. We do identify Philly-like, more immune-mediated therapy and CAR therapy. Finally, allogenic transplant, haplo, half match as an option. Everybody has a donor. Everybody has an access to a cure intent therapy. We remain with a lot of challenge with Philly-like, And even if you ask me, JAK2 inhibitor improve outcome in adults, no. And we need to work more on the CAR-T and immune therapy. And TKI kinase inhibitor involved and improved the outcome in Philadelphia positive of ABL1 or EPOR-related disease. Different recipe. It's like you go to a restaurant. You have the USC regimen, CAL, GB, BFM, whoever, whatever you feel like you're comfortable with. The whole idea is combine multi-course of induction, consolidation, anthracycline-based, PEC asparaginase, and we got all excited about that, including the pediatrics-based regimen, St. Jude and others, to an adult patient in older age. CALGB 10403 included PEC asparaginase up to 50-year-old. Of course, the disease-free survival was exciting, 69%. Dr. Yaghmour, no transplant, you have to retire. Well, not everyone wouldn't require transplant because we still have the BMI, the obesity, feeling like those patients has to drop from this protocol and they have to require salvage treatment. This is my regimen that I'm publishing. Also, we presented the data in ASH, modified USC. We moved around. We dropped the methotrexate. I moved PEC asparaginase, and I give my patient more holidays. And that's will require for me to give 1 induction, 2 induction, then finish 6 consolidation, then pump maintenance. It's very easy to use for us, and even community doctors around who refer patient to me, they are able to use it. We max the PEC asparaginase dose because the next challenge in management in ALL, how familiar and good we are in managing toxicity of the treatment, especially with PEC asparaginase and others. So this is updated outcome from our cohort in patient has received Blen or not. As you see, patient who received blinatumomab, they did worse because those are the higher risk who has MRD positive compared to the Kaplan-Meier survival for a patient who didn't get it using USC regimen. And this is comparing Hispanic to non-Hispanic. We did good job. In Hispanic patient, 3 years survival, it is over 75 and 80% for those patients if they didn't get Blen and they have MRD positive and Blen, if they didn't overall, regardless of the transplant, their survival curve dropped, and that's next asparaginase, different form. We have the short half-life, we have the pegylated E. coli asparaginase, calp asparaginase. At the end, my question to the group, when you do pediatrics-based regimen and assume you are doing it, you guys do a great job at St. Jude here. But in adult, nobody checked the activity at day 7 and day 14. You have to send it on an ice pack sample, purple top, and you need to see at 7 and 14 that the level is above 0.1 units per milliliter. I mean, how many times we say, hey, there is some rash, some reaction. How do we know it's antibody-mediated or not? Next, we check ammonia. If it's high, it's unlikely to be antibody-mediated. But if it's not, then you have to switch to Erwinia. And basically, you don't want antibody silencing. You want to optimize the depletion of asparagine to achieve MRD negativity. This is highlighting how to manage high toxicity with asparaginase. We come up with a dose adjusted based on the age for patient. Asparaginase might still benefit. Even if it's not 2,000, you can do down to 500 in 70-year-old and older if you want. PEC asparaginase, if it's having reaction or antibody-mediated, we switch to Erwinia with published data in the phase 2, led to approval with improvement in the toxicity profile, short half-life. We give it Monday, Wednesday, Friday. Friday is higher dose because we want to go through the weekend, and it's 25, 25, 50. Primary refractory, MRD positive, genetics marker, relapse within 2-3 years are factors that influence survival in this patient. Philadelphia positive 9, 22 translocation remain a challenge, carry worse 5-year survival, different TKI, imatinib, dasatinib, ponatinib, bozatinib, nilotinib, asciminib, a lot of different regimen. We do know SWOG hyper-CVAD combined with dasatinib led to improvement in survival in adult, young adult, but the plan was reduce the dasatinib dose, don't give the 140, 100 milligram, then reduce the dose to 70, and the plan was to do transplant for all this patient population, especially that was the design of the group. 3 years survival 71, event-free survival 51. I mean, definitely in the setting of TKI, we publish here database, survival has improved when you use TKI. Whatever in older age, steroids and TKI, ponatinib, nilotinib, dasatinib, different group. Europe showed you here good survival and response rate even in the chemo-free regimen, just doing steroids and TKI. But if patients are older and they are relapse refractory, which is 60%, they will carry the gatekeeper mutation, T315I mutation. And now the data from MD Anderson propensity score, ponatinib in hyper-CVAD compared to dasatinib has 3-year survival benefit, and of course complete molecular remission higher in ponatinib than dasatinib. We amended the protocol. We reduced the dose from 45 to 30 and 15 milligram, and we did have to make sure everybody get 12 doses of IT chemo. Dasatinib has access to CNS, ponatinib did not, so we have to accommodate the total number of IT chemotherapy. CD20 is expressed in 30–50% of pre-BALL, carry poor prognosis, and we can definitely consider when you see the GRAL study and the initiation of the GCO paper by Thomas that adding rituximab improved 3-year CR and survival to 75 and 70%. So make sure CD20 status is checked, and always a challenge with pathology. Oh, I'm not sure, 20% or less, because that's a defining point. If not above 20%, you cannot add rituximab. How about like 1% or more? It's enough, and you use the ofatumumab and the next generation CD20 antibody, and that's a study showed 3-year survival benefit with 70% survival, and regardless of the CD20. Next, blinatumomab bispecific combined CD3, CD19 single cycle of continuous pump induction. Consolidation, it's a total of 28 days, 2 weeks breaks, total of 42 days. The initial FDA approval was relapse refractory, failing multi-line of therapy by TOPS and Katrajian group. Now we have the BLAST. This is the New England publication for the initial survival benefit FDA approval. Blinatumomab showed significant longer survival compared to chemo salvage. Look at the survival curve in the New England. This is what we want to see. I showed you earlier the survival curve that we are heading to. Do you need to wait to introduce BLAN to fail 2–3 line of therapy and get up to this survival curve? BLAST study introduced the blinatumomab in the MRD status, and definitely Blincyto for MRD positive showed significant improvement. This is 5-year data and long-term follow-up that survival improved in 5 years, and MRD negativity patient achieved longer-term durable remission. In the BLAST study, the question, who do you transplant? Anybody who is in the relapse setting with MRD positive and the younger age, those are the only people benefit from transplant in BLAST study subgroup analysis. This is superior survival. If you include, in the next 7 slides, I'll show you blinatumomab data with pediatrics and adult, overwhelming. If you include it in consolidation pre-transplant, you are seeing survival benefit even in lower level of disease. And this is super survival or superior survival compared to chemo as a pre-transplant consolidation in children cohort. And of course, his Blincyto showed if you add it as subsequently to hyper-CVAD, also survival. That is a HOVON trial that showed us Blin added to preface and consolidation in newly diagnosed adult showed survival. And next is chemo-free, the ALBA and FILI positive. If you want to talk about no more chemo, just a steroid, and then add with the dasatinib and add blinatumomab after 3 months required at least 2 cycles. As you see, the survival and disease-free survival is over 85%. Chemo-free induction consolidation with FILI positive has great survival data. However, still, Icarus, zinc, PAX, cyclin D kinase, they didn't do as good. They need required chemo, and they have significant disease-free survival lower numbers. That's why our pathologist has to tell us in FILI positive. Even in FILI positive, not every FILI positive is the same now. We have to look deeper about what is the biology. This is my data for FILI positive using USC regimen with TKI, dasatinib. You see the survival curve with transplant, without transplant. This is like almost over 90 to 100% survival for high-risk Hispanic population with chemo combined with TKI. If I get 3 months MRD complete molecular remission, I wouldn't really be nervous about offering transplant unless I have Icarus zinc or significant extramedullary risk of relapse. If the patient is not interested to continue 2 years, or they have liver steatosis and asparaginase challenge is going to be a problem, please you should consider that and don't wait for relapse refractory. So what about transplant needed in CR? Toronto showed us, no, not really. If you get to complete remission, there is no statistical significant difference if you do transplant or not, if you achieve complete remission. This is a 40 months follow-up from Jemima, the ALBA protocol of purely dasatinib steroids with blinatumomab. However, the risk of relapse, the higher risk, how about the randomized phase 2 study, ponatinib with blinatumomab in the upfront relapse refractory MRD positive? The dose has reduced from 40 to 30 and 15 milligram after CMR, maintenance of 15 milligram, and that's also added to blinatumomab. This is a phase 2 trial, 2 years event-free survival. Survival was published and presented recently in the long-term follow-up with very promising, over 90%. That's basically should be our new standard in older patients with Philadelphia positive ALL. Finally, the ECOG 1910 randomized phase trial that showed us survival benefit when we randomized patient to blend or no blend and chemo. And basically, this is the trial published in New England Journal of Medicine that showed us 488 patient, median age of 51, 224 MRD negative, 1-to-1 randomization blend or chemo. Blend has survival benefit, but the question is the number of total courses. Do you need 4 or 2 cycles? At least 2 cycles is important. No difference if you do in the subgroup analysis transplant in patient who achieve MRD negative. So chemo with blend in newly diagnosed MLL. What about the KMT2A? Now we have revumenib FDA approved to target this, and also blinatumomab improved in higher risk patient with MLL in the childhood. And of course, excitement of subcutaneous form in the early phase, and we want to see if we can inject now, not pump IV, and that's basically the data. And I am very much excited because majority of my patient comes from distance, up north and Vegas, so subcutaneous blend in relapse refractory might change my life. Inotuzumab ozogamicin, it is a targeted antibody and targets CD22. Innovate study led to approval and showed us survival benefit. That's not the Kaplan-Meier survival that we need. That's why we introduce it now more in relapse refractory to dose-adjusted epoch. That's very highly used by community, and definitely I do think this is very reasonable data to use for community doctors and extramedullary high-risk patient, relapse refractory dose-adjusted epoch with inotuzumab. And of course, now I know with hyper-CVAD with blend showed us very, very good phase 3 data that if you include inotuzumab with CALGB, also 3-year survival and event-free survival is good. Mini-CVAD, less chemo with inotuzumab. Now the question you have, high 50% or more blast, what was the best approach? You can go chemo-free, give inotuzumab single agent, get them reduced, and then do blend. And after blend, you watch and wait and or continue maintenance. This is presented in ASCO, that's chemo-free regimen, older age, you give ino, after that, just blend. This is the data, early phase, chemo-free regimen, 1-year event-free survival was over 75%. Are we transitioning to chemo-free regimen using INO, then followed up with blend in older age? What is the rule of doing CAR-T therapy in MRD positive? A lot of other agents, including the isatixumab for CD38, CAR-T therapy. I don't have enough time to cover CAR-T, but we know we have a lot of products, including TISA-cells, Bresu-cells, and the recent approval from the study of the new products, Obe-cel, from the Felix study, that you have the reduced affinity, more expansion, less toxicity. I'm just going to show you that's a grade 3 toxicity for ICANS and CRS is 3%, 7%. This is the products that are going to be used in the outpatient CAR-T patient. The dose is different, depends on the blast count. It's excitement for us to start using the products in the clinic, and BCL2 inhibitor, and of course, in conclusion, we had significant progression. Are we transitioning to chemo-free, subcutaneous blend, involve blend and inotuzumab in the setting of upfront and chemo-free regimen and CAR-T-free? Less alkylating agent and chemo, maybe healthier cells, better CAR-T. Do you need transplant for everyone? That's an exciting time. Thank you all for your attention.